The views you are about to hear are not necessarily the exact opinions of the participating physicians. They are expressed as differing points of view in this unique medical education setting, exploring best practices in PH patient treatment.
Court's in session. Today, our case is, should CTEPH patients post-intervention be treated with advanced PH therapies? The question today really relates to what sort of intervention should occur in these patients in terms of medication following a surgical or procedural intervention. And should these patients, in fact, be treated with medical therapies? We know that surgery or pulmonary thromboendarterectomy, PTE, to remove chronic blood clots is the treatment of choice in these patients. And in patients who are surgical candidates, this treatment can be even curative. However, in a small proportion of patients, pulmonary hypertension may remain. An additional intervention, balloon pulmonary angioplasty, in appropriately selected patients, may be an alternative treatment for patients who are non-surgical. In patients who've had an intervention and have residual pulmonary hypertension, should these patients be viewed the same as any patient with pulmonary hypertension and therefore treated appropriately? That's going to be the question at hand. So let's get right into it. We'll start with Dr. Forfia, who will argue the pro side.
Thank you, Your Honor. Balloon pulmonary angioplasty has been initially used to treat congenital pulmonary artery stenosis. However, these techniques have been extended now into a subset of patients with chronic thromboembolic pulmonary hypertension, or CTEPH. We will be discussing that. PTE, of course, has been the treatment of choice for patients who are amenable to surgery with CTEPH. In a select population of PTE patients and in BPA patients, pulmonary hypertension does persist after the procedural intervention or the surgical intervention. And the question is, how do we manage these patients who still have residual disease? Studies in CTEPH have included patients with a mean pulmonary pressure greater than 25 as an inclusion criteria. Obviously, the results of these studies should be generalizable to patients after BPA and PTE. PAH medications now available have been approved for the use of CTEPH. We intend to show that the use of medical therapy can provide continuing benefit to patients with residual pulmonary hypertension after pulmonary thromboendarterectomy and after BPA.
Thank you, Dr. Forfia. Dr. Krasuski, please give your opening.
Thank you, Your Honor. Chronic thromboembolic pulmonary hypertension is a serious disease. The morbidity risk is high, even for patients undergoing surgical thrombus removal or BPA. Currently, there's only one medication, riociguat, that has been FDA approved for treatment of chronic thromboembolic pulmonary hypertension that's considered inoperable or post-PTE, residual pulmonary hypertension. Should we extrapolate the efficacy of this single drug to all PH-specific therapies? However, evidence is suggestive that the best evidence for use in these patients exists in those with the highest level of mean pulmonary artery pressure elevation. We plan to show, Your Honor, that the clinical evidence is lacking for the use of medical therapies post-PTE, particularly for those that are post-BPA and in patients who have lower pulmonary artery pressure, particularly outside the use of riociguat.
Thank you, Dr. Krasuski, and thank you both for your opening statements. Dr. Forfia, you may call your witness.
Following effective opening statements, Dr. Forfia will question our first witness, Dr. Rajan Sagar.